Brian Magovern. I work here in Torrance. This is my group. We only have 6 of us on this picture, but there are 7 of us. We've just introduced Saturday office hours. We have specialists in pretty much every department. So the way orthopedics works is you do a 5-year residency program, which is all of orthopedics, and then an additional year in something else. Now, I did shoulders and elbows, but we have a spine doctor, we have a hand doctor, we have joint replacement doctors, so we kind of have all bases covered. So I do primarily shoulders and elbows, but I see patients with all kinds of problems. So I see backs, I see feet, but if it's something that needs further specialty, I can send you to the right place. So I get the opportunity also to work at Harbor UCLA. Most of you probably know this as Harbor General. So I'm the only one in my group that works down there, and I do 2 half-days a week, doing mostly shoulder and elbow trauma that comes in off the street. It's a huge experience for me. I have residents that are doctors in training that I'm teaching there. It's a trauma-heavy institution, so we have, again, really complex injuries. We have a tough population that a lot of times they don't really do what they're supposed to do, which is kind of why they got there in the first place. And it's sometimes hard to follow them, hard to get good treatment. And here's kind of just an example of what we deal with down there on a day-to-day basis. So this is a 36-year-old man, and you can see that shoulder doesn't probably look quite normal. I think most of you would agree that he was actually shot by his own cousin because he owed him maybe $50 or something like that. And if you look here, you can see that his humeral head is broken into tiny little pieces, essentially shattered. And so we had really no choice but to do a full shoulder replacement on this 36-year-old man, which is really amazing. So why the shoulder? This is probably a question I get asked so often. It was the first rotation that I did when I was a resident. So I was a brand new second-year resident, came onto the shoulder service, and when you do, whatever your first service is as a resident, I think you kind of measure everything else up to that. And it was just the thing that interested me most, and there really was nothing else that came along that quite did it for me. The shoulder's amazing. It's capable of so many things, and reaching and grasping and lifting and clearly throwing. As you can see here, it is a very complex anatomy, more complex, I think, than the hip, the knee, because of all its functions, all the things that it does. I think it requires that complex anatomy. It's also the largest, it has the largest range of motion of any of our joints. And you think about what the shoulder does, it allows your hand to get out in space, and the sphere that you can get to because of your shoulder really is vast and quite amazing. So this is just a funny picture. This is one of our original papers from the 50s. And this is how we know that it's the joint that has the largest range of motion. This is a paper from a famous shoulder surgeon named Charles Rockwood. And these are medical students and military recruits that were volunteered to have pins driven into their bones and their shoulders so they could measure the degree of motion as they moved their arms through space. So I think this is how medical students back then got into residency programs, was by volunteering to be the guy that gets the pins drawn into them. So because of that complex anatomy and because of the tasks that the shoulder is capable of, it's also frequently injured. And whether it be sports injuries or work injuries, and again, work injuries aren't just swinging a hammer, it's repetitive use. It's having to do the same task over and over again and reaching up and putting up. And these are really frequent ways that I see shoulders injured. And then, I have to put it politely, of course, but maturity is always something you got to worry about. And when you need a nurse to hold you up when you're swinging your golf club, there's a chance that you're going to injure your shoulder. So now, injuries are also starting a lot earlier, and so I see younger kids and I see a lot of younger girls, particularly. Girls' sports have dramatically increased with injuries since, I guess, since I was a kid even. And these injuries are painful, they have long rehab, and they're a major cost to society. So what do we do about them? Well, we have a team approach, and that's what's so great about a discussion like this, is we have 2 people from both sides of the spectrum that both have the same goal, which is to treat that same patient. And there needs to be a team approach, and there needs to be communication. So while we might not talk on the phone, we have reports that go back and forth, and now we even text each other once in a while about different patients and updates and try to use technology to help that along. It's important to realize that the history and physical exam for Danica and myself both remain the primary diagnosis method. So we have an idea what is wrong after the first 3 minutes of hearing and moving and testing and checking things out. We don't necessarily need an MRI scan. So a lot of patients come in and I say, well, tell me what's wrong. And they say, I need an MRI scan. Well, we're going to have to start and back up a little bit. Tell me your symptoms. It would almost be like saying that a chef only needs a microwave because it's the most recent thing that has been invented. And so why would you need anything else? Well, I think you're still going to need pots, you're still going to need pans, you still need burners, all these things. So the old-fashioned history and physical really still is the most important thing. Yes, we do use images. This is an X-ray and this is an MRI scan. And I think that it's a common thought that an MRI is just plain better than an X-ray, but it's not the truth, actually. It's really a myth. So they both look at two very different things. And you can see that the X-ray above really outlines the bones nicely, versus this is the MRI on the bottom screen. And you can see the bones look okay, but really this shows all these intricacies, all the soft tissues, the tendons. And yes, this shows a lot, but this gives me a lot of information. I can make probably 4 or 5 diagnoses just from that X-ray alone. This is about $40. This is about $1,000. And this is very quick and easy. I can do it in the office, and I can oftentimes preclude the need for a test like this. And here's just a good example. So calcific tendonitis is one of those conditions that I see fairly frequently. And so if you just jump, and calcific tendonitis presents like many other shoulder problems. It presents like a frozen shoulder, like rotator cuff tears, but it's not that common that you all probably haven't heard of it much. And here's the MRI for calcific tendonitis. And again, I know that you all don't know that, but this is a normal MRI scan here. Oh, my pointer's not working, sorry. That's a normal MRI scan. The rotator cuff looks good, everything looks great. It looks fine. So if you just got that, you would miss that. Sorry, the pointer's not working. I don't know if you guys can help me fix that. But if you look at this MRI, if you look at the X-ray, you can see that there's this big fluffy calcification right here. It's all in the tendon, and you don't see it on that MRI scan. So it's something that would be totally missed if you just jump right to it, and that's a fairly easy treatment. It doesn't, I'm showing you this for dramatic effect. It doesn't always need surgery, but when it does, this is how it comes out, and it kind of comes out like toothpaste. But again, if you didn't get that initial X-ray, you would never know that this was the problem. And so this is the rotator cuff. And this is, and again, I'm sort of just pushing on it to squeeze out all that calcium, and there it comes. And that calcium acts like a little marble, and it just causes a mechanical impingement, and it releases fibers and things that cause a lot of pain. Yeah, the question is that a vacuum? It is kind of. It has a suction attached to it and those shaver teeth, and so it sucks up the bad tissue and it leaves the good tissue. It's a very smart device. I don't really know how it does that, but I wish I had invented it. So again, the shoulder has very complex anatomy. There are 4 joints that make up the shoulder. If you look off to your left, did we get this going yet? Okay, so this is the sternoclavicular joint. This is the acromioclavicular joint. This is the glenohumeral joint. And then it's not technically a joint, but the shoulder blade sits on the back of the chest wall. Acts almost like a joint, but it's really just a bone rubbing over muscles. Each joint surface is covered with a smooth cartilage, and you've seen this on the end of a chicken bone, and that's what allows it to move friction-free and has relatively little pain. Every joint in the body is also surrounded by a capsule, and that's the next layer out. And what that capsule is really just a bag that holds the fluid in there. There's a thin layer of fluid that also allows that joint to have a lubrication and allow it to move smoothly, and it needs something to hold that in, and that's what that capsule is. This is also where you will find ligaments. A lot of them are ingrained in that capsule. A ligament connects a bone to a bone. A tendon connects a muscle to a bone. And that next layer out is where you see the tendons. And so this is the rotator cuff, and these are the muscles, and you can see the muscle comes out to the humerus and turns into a tendon and grabs the bone. And we'll talk about that more later. So again, the shoulder is very interesting because there are a lot of things that can go wrong. There is a huge spectrum of treatment. There's vast disagreement among experts. I go to these meetings and we argue back and forth about the primary cause of something, which is great for moving the ball forward in our field. It's a little confusing for you all when you go to two doctors and get two different opinions, but you do have to realize that that's for the better of society and you and all of us eventually. But the bottom line is proper diagnosis, rehab, and surgical treatment is very crucial. Revision surgeries are rarely as good as the primary, so you really hope to get it right the first time if it's necessary. And Danika's going to talk a little bit too about prevention, but prevention really goes a long way. So that's the start. Now Danika's going to give us a talk on some of the basics as well, and we'll move it along to, we're going to do 4 common shoulder problems, and then we'll go into the questions.
Great. All right. So I'm going to talk a little bit about just what physical therapists do, and hopefully answer some of your questions as to why PT may be important for shoulder rehab. So therapists, patients, doctors all agree that shoulder is one of the most difficult joints to treat. It's also one of the most painful because there's so many different directions that the shoulder moves in. There's also a lot of nerves that can go through the shoulder area, that it can be a really painful process to go through. We use our shoulders for everything, lifting groceries, opening a door, putting on a jacket, driving, everything. We use it more often than we think, and you don't realize that until you have an injury. So my job as a physical therapist is to make these everyday tasks much easier and take away some of the pain. So when a patient first comes in to see me, I always evaluate them for certain impairments such as range of motion, strength, and any postural deficits that we may see. So in order to help patients achieve their functional goals, I need to address these deficits. So first, restoration of range of motion, which we always abbreviate as ROM. So in order to do this, there's several different techniques that we use, stretching being one of the most popular, common ones that many people know and they don't have to go to a PT for. But we also use techniques such as myofascial release, soft tissue mobilization, massage, trigger point release, and also joint mobilizations. Strengthening is also an important part of the rehab process. When there's a tendon or a structure that's overused or it's wearing down, it's usually because something else isn't doing its job sufficiently. So we need to figure out what that muscle is, what are the weak muscles, and what can we do to normalize that. Posture, like I said, is a very important part. As you can see in this picture down here, this is a very common postural impairment. Especially with texting these days, people's heads are always down, and computers too. People who may or may not have, or people who may have impaired vision, their head comes forward a little bit, and that can really affect not only their shoulder, but some of those neck muscles too. So it's very common to have shoulder impairments in addition to neck impairments, and have some pain there as well. So many of you also want to know about preventing future injuries, especially parents of some young competitive athletes maybe, and then sometimes when you have an injury on one side, the other side may also later down the road get some wear and tear. So prevention is a huge part of my job, and hopefully we don't have to see people again. So I did want to go over the anatomy of kind of the neck and shoulder muscles. And if you can, hopefully you can see this clearly, but I think it's most important to kind of pay attention to the direction of the muscle fibers, because that controls how the shoulder blade moves. So not only just looking at the muscles, but you can see these fibers go up this way, these come down this way, and ideally you want those muscles to work together to move the arm up. It's very common, as I referred to on the last slide, with the forward head posture, for people to have just this muscle up here. This is called your upper trapezius. And then you also have your levator scap right there too. And those two together can cause a lot of tension in the neck and then affect how the shoulder moves. And then it inhibits, unfortunately, some of these more important muscles down here, which is called the middle and lower trapezius. And those should all work together nicely to elevate the arm. So that's why posture is really important. And then on this side of the drawing, some of the muscles are peeled back, and you can see some of these rotator cuff muscles that Dr. Magovern just referred to, and how those can affect the movement of the arm too.
Okay, so now we decided to pick, we could have talked about 10 or 15 topics probably, but we picked probably the 4 most common things that we see. And certainly if there's any questions about other pathology, somebody might say, oh, well, I had a avascular necrosis or something that we haven't covered, just raise it up in the questions. But we're going to talk about rotator cuff tears, we're going to talk about frozen shoulder, we're going to talk about shoulder instability, and shoulder arthritis. And I'm going to focus on some of the anatomy and some of the surgical treatments, and Danica is going to talk about the rehab and how it's affected by that. So let's start with the rotator cuff. This is probably what I see most commonly. So again, this is that same picture I showed before. This is the humerus right here, and this is the ball, and that's the socket. And again, remember, there's a capsular layer that's holding that ball and socket together. That ball is covered with cartilage. That cartilage is typically normal in a rotator cuff problem. So we're talking about the third layer out. We're talking about the tendons and muscles. And this is the front of the rotator cuff. This is a front view of the shoulder. This is a back view of the shoulder. And the rotator cuff really comes out from the shoulder blade as a muscle, as 4 different muscles that then turn into a tendinous cuff. And when you look at it from the side, what you can see is, again, this is the humerus coming up, and the rotator cuff comes out from the shoulder blade and grabs all the way around, and that's what helps turn the ball inward, outward, and up. And you can see this is the shoulder blade above, and that is part of some of the pathology that, again, experts disagree. There's big debate as to whether the shoulder blade pinches down on the rotator cuff and causes tearing, or if that really has nothing to do with it. But you can see this is a little bit of an outlet, if you will, where that rotator cuff has to move through. Rotator cuff problems are the most common reason that I see patients with shoulder pain who are over 50. So this is not typically a very young person's disease. This is not a problem in 20-year-olds. So I have probably fixed 1,000 rotator cuffs, and I have done 1 in a patient in their 20s, and I've done 3 in patients in their 30s. So this is typically 45, 65. It also reaches a ceiling, and I don't typically do rotator cuff tears on 85-year-olds. There's other problems at that age. There's arthritis and other things that we'll talk about. So it's typically in this age range, and it's not because there's anything special about that age range. It's just that that's the age where blood flow starts to slow down to tendons. So it's not just the rotator cuff. It's quadricep tendon tears and patellar tendon tears and biceps tears and all of the tendons. It's sort of that tendon age, if you will, where tendons start to wear out. Typically, patients present with 2 things, and night pain is a big one, and overhead reach. So classic story is, I'm a 55-year-old accountant, and I play softball on the weekends, and I try to throw the ball overhead, and I can feel that pinch, and it hurts, and I go home that night, and I try to sleep, and it aches, and I feel this cramping, aching pain. The thing that's difficult about it is that there are a lot of people that are out there that have an actual full-thickness tear in their rotator cuff, and they don't know it. They can be asymptomatic, so when somebody comes in, say with an MRI that shows a tear in the rotator cuff, I got to make sure it's not something else. I got to make sure it's not coming from the neck or the trapezius or some other area. So sometimes that's an issue. Now, neglect can lead to problems in the future. I'm going to show you a dramatic video. I don't want you guys to run out to my office tomorrow because you're nervous this is going to happen to you. But this is sort of the end result of bad rotator cuff disease. This is a woman who had a replacement done for fracture and now has an inability to really control the ball in the socket. And you can see when she tries to reach up, she has it's almost an involuntary dislocation of the shoulder. And so this is called anterosuperior escape. It means the humerus just really has no containment, and it's a very painful condition. There's a salvage option that's out now, but it's only been recently introduced. So you can see again from the side. There it goes. All right. There are rotator cuff disease comes in kind of a spectrum. There are early stages of rotator cuff disease where the tendon hasn't torn off the bone yet, and these are what I call partial thickness rotator cuff tears. The example I always give in the office is it's like a carpet. You walk on your carpet for 45 years, it's going to have a thin area. That's a partial thickness rotator cuff tear. Once it's ripped and you can see the floorboards, that's a full thickness tear. We treat the two of them very differently. The earlier partial thickness tear is the same as all of these terms that you've heard before, possibly: impingement, bursitis, tendinitis, bone spur. That bone spur is what I described as the shoulder blade coming down and pinching on the rotator cuff. These are all the same thing, and these are all early rotator cuff problems. There's nothing that you can do about it. This is a problem that happens with age. Your tendon blood flow is not great. The best you can hope for is stay active, eat well, have great genetics, which someday maybe you can alter, but not yet. But these are all early rotator cuff tears. They can all look like full thickness tears. So this is one place where an MRI really helps. So an MRI can distinguish a full thickness tear from a partial thickness tear. So this is one of those areas where it's probably best used. But again, that's after your good history and physical exam. The early stages of rotator cuff disease, particularly the partial thickness tearing, we can treat with rehab, cortisone injections. I hear a lot about cortisone. Maybe we can save that discussion for the questions, because I'm sure a lot of people will ask about that. But these tears will not heal without a surgery, but they don't need to heal. So you can get a tear that becomes asymptomatic with proper rehabilitation, non-operative treatment. Here's what one looks like. You can see here that, again, that's kind of that same picture I showed you before, the humerus, and this is this big cuff around it. But the tears happen typically in one place, and this is a smaller tear, and you can see that it kind of rips it off the bone, and that's that analogy of you can now see the floorboards through here. This is what it looks like arthroscopically. This is the bone, this is the tear, and this is obviously going in to repair it. We tend to be a little bit more aggressive with certain patients. So patients that are younger, patients who have traumatic tears. So if that rips off from a motorcycle accident, which doesn't happen that often, but if it does, it's not like a wear and tear, blood's not flowing well, and it just failed. It got ripped off, and so to put it back on, it still has healthy bleeding tissue that can heal and heal very well. And then larger tears we tend to be a little bit more aggressive with surgically. But the vast majority of rotator cuff problems that I see in the office, we can make better and essentially go away in conjunction with physical therapy, the right rehab. So also tears that fail to improve. So once Danica has done everything she can, I've given a cortisone shot, I've done everything I can, that's when we start looking at rotator cuff surgery. I don't tread on this lightly. It's a brutal recovery. It's painful. It takes 6 to sometimes 18 months to get over, and it's really a harsh thing. Now, if I can play this video, this is just what it looks like arthroscopically. Now, there is discussion about open versus arthroscopic. There is nothing wrong with doing an open rotator cuff repair. I do probably every 100 that I do, I have to do one open just for certain reasons. But again, you can see this is similar to those pictures we had before. This down here is the ball, which you can't see. This is the bone where the tendon is supposed to be. And this piece right here is the tendon. And so what I'm doing is I'm bringing an anchor down, and that anchor goes into the bone. And that anchor is going to have some stitches on it. And I have some special equipment that takes those stitches and then passes them through the rotator cuff. You can see we drive that down. Whether it's done open or arthroscopic, the healing time is the same. That tendon still has to heal down to the bone. So really, an open rotator cuff repair doesn't buy you much except for maybe a smaller scar. There are some studies now suggesting that maybe it's a little bit less painful, a little bit of a faster recovery, a little bit less risk of stiffness, but overall, it's still, everything has to happen the same inside the body. Despite what we think, we hear the ads from other places saying that they are going to speed up your recovery because it's done arthroscopic. Well, it's still the same problem. You still have to get that tendon to heal down to the bone. You can see the stitches going up underneath. In fact, when we do an open rotator cuff repair, we use the same instruments. We use an anchor and stitches and sew it through with a needle. So it's really the same idea. And you can see again passing that needle up through. Which white stuff? This white stuff or the stitch? The question was, what's the white stuff? I think the question is this white stuff. That's the tendon itself. So that's the actual tendon. And again, I have all these corny analogies. I'm sorry, but my analogy is that it's like when the blankets get down to the bottom of the bed, and what you're trying to do is bring that blanket back up to where the pillows are. And so it kind of looks like a blanket. And once you pull it up there, that is the tendon itself that you're trying to bring back down. And if you followed that tendon out farther, you would eventually see those muscle fibers that go all the way out to the shoulder blade. And this is just an extra row that we do now that lays those stitches down flatter and fixes the repair a little bit nicer. And a final anchor. And it takes about 45 minutes. It's typically done as an outpatient. And the recovery's tough, but the surgery is relatively straightforward.
So these are some of the techniques that we use to rehab patients who have rotator cuff involvement. The first one, the first and most important part, again, is to decrease pain, as that's why many people come to the doctor. So we use modalities such as electric stimulation, ultrasound, iontophoresis, and heat. Obviously, heat and cold packs too can help to decrease some pain too. And they also help to increase blood flow, which can help to promote healing as well. We also use what we call manual therapy, which can include stretching stiff muscles or shortened muscles, joint mobilizations, which is when we actually use our hands to move a joint that may or may not be moving very well. And that can help to stretch out joint capsules, which if you can visualize back to the anatomy that we went over, some of those tendons just get really stiff and the capsule tightens up. So we use our hands to increase that motion. And we also use what we call muscle facilitation. And oftentimes, muscles are so deconditioned that our brain may not even recognize certain muscle groups. So PTs use our hands basically to, quote unquote, wake up certain muscles and get the brain to recognize these muscles. And then we'll work on strengthening those muscles. And that, if you remember back to the anatomy that I showed you, oftentimes it's those scapular muscles, the middle and lower trapezius, that are inhibited because some of the other muscles, like the upper trapezius, are very stiff. We also do what we call therapeutic exercises, and these include rotator cuff strengthening exercises, which I will go into a few of them later because I know a lot of you are here because you want to learn what you can do to prevent some of these injuries. So we use some exercises for internal and external rotation, which is this motion right here. And we often start at a neutral down in here. And then as the patient gets stronger, we'll progress up into these open positions, which are a little bit more challenging. We also will focus on scapular stability, like I talked about, using those middle and lower trapezius muscles in the back to stabilize the scapula. Because if the scapula moves too much, then oftentimes there's too much movement inside the glenohumeral joint, and that's when some of those rotator cuff tendons get irritated. So like I said, we'll cover a few of these therapeutic exercises later. And then patient education, again, is a huge part of my job. We try to educate patients on how to avoid further tissue damage by, avoiding certain positions. So if somebody is really irritable and painful with any reaching movements, we teach them, well, don't do that. It's the old saying, if it hurts, don't do that. And it seems intuitive, but it's not always. So we do a lot of patient education and also teaching patients how to sleep because that can be a really hard thing to do when your shoulders hurt. And then again, posture. So we do a lot of exercises for posture and a lot of just cueing and reminding patients, well, straighten up, sit up tall, kind of like your mom used to tell you when you were younger. So. All right, and then the post-op rehab. Again, like he said, it's a very long rehab, but luckily, there's been some advances in surgery in the last, 10, 15 years, so that's made the rehab process a lot easier as well. So we see patients typically for, we can 4 to 6 months, sometimes even longer, especially if they've had revision and it's not their first surgery. It can be up to a year or more, so we get to know each other very well. So again, for post-op rehab, again, a lot of education, teaching patients which activities to avoid, how to wear their sling properly. I can't tell you how many times I've had patients come in and saying, how do I wear this thing? And so we have to go over, how to wear that properly. Or sometimes patients aren't even wearing their sling. And again, that also depends on the surgeon, because every surgeon has a different protocol that they abide by. And it also depends on the amount of repair that they did. The larger the repair, the more strict the protocols usually. So, and every physician's different. So communication between the PT and physician is extremely important. So then the next part of our rehab process is to restore range of motion. And this is to avoid adhesions and fibrosis, which will help to reduce pain and allow for collagen healing and increasing tissue flexibility. So as directed by the physician, we do stretches in certain ranges. It depends on the repair, how big the repair was, which tendon was repaired, and that dictates which motions we can or cannot stretch it into. So it really varies patient to patient. And we always start initially with passive stretching, which means the therapist stretches the patient, or they use gravity to stretch the shoulder joint. It does not mean you can raise your arm up. And then we usually progress to assisted active range, which means you can help lift your arm up with your other hand, and then eventually to active range, which is lifting your arm up. And then we use, like I said, modalities earlier, and that can help to decrease the pain and inflammation. And then eventually, once the tendons have healed, we can start some strengthening. Initially, right off the bat, we'll start with some scapular strengthening, and usually that just includes like squeezing the shoulder blade just to get a little bit of scapular movement, because that does not involve the rotator cuff directly, necessarily. So we will progress the exercises according to the tissue healing time frame and how the patient's doing, and go from there. And then, most patients make a full recovery. They gain strength and range of motion to within 10% of their other arm usually. It takes a long time to get there, but most patients do really well.
Okay, so the next topic is going to be frozen shoulder. This is more common than it seems. I see a lot of it. It happens in about 2% of the population. It is more frequent in women, typically ages 40 to 60. And instead of that night pain and that overhead pain, this is pain typically with end ranges of motion. So any direction, once you get to that end range, hurts. So yes, it's going to hurt you reaching overhead, but it's also going to hurt you to reach behind in the back seat of the car, and it's going to hurt you to reach behind and scratch your back, any direction that you get to. There's a high correlation with diabetes, although most of the patients that I see do not have diabetes. They have what's called idiopathic, which just is the word for saying we don't know what caused it. Again, history and physical exam is crucial. I make this diagnosis, and I will maybe get an MRI scan if it's been 6 months in and they haven't gotten any better, but history and physical tells me everything. So this is 45-year-old woman presents and says that oftentimes there's some history of trauma where I was picking up a heavy pot, but yes, that may have triggered it, but it's probably not really the thing that did it. It probably just was going to happen anyway. And it just develops kind of insidiously and slowly, and then over the course of a couple of weeks to months, now it's kind of the point where it's really sore for me. This is a really important diagnosis, and we have a term where as doctors, where we say, well, you might not have seen this, but it has seen you. So it's been to your office and you missed it. So it's seen you, but you missed it. You didn't see it. So this is often misdiagnosed. And it's misdiagnosed mainly because it doesn't present as a frozen shoulder. It presents as a painful shoulder. So it starts out as pain, and it's pain well before the stiffness part even kicks in. and that can be variable. It can be for weeks and even months before they really get significant motion loss. It's not really talked about very much either, and that's what's funny. And you hear all of your neighbors are willing to talk to you about every shoulder injury they've ever had, and the rotator cuff and this and that, but you don't hear people talk about frozen shoulder very often. So I think it's just not known about out there in the community. But it's easy to diagnose. You have somebody who has pain and stiffness in every direction. We don't know what causes it, but it looks a lot like impingement and those other sort of partial thickness rotator cuff tear things that I talked about at the last segment. But impingement type surgery or operating on a rotator cuff can be very harmful if you do it in this early stage. So again, history and physical exam are the most important, and it's so poorly known that when you go into our major PubMed is where we go to look up all of our journals, and you type in frozen shoulder, and instead of getting articles on frozen shoulder, you get assessment of welfare of finishing beef cattle kept on different types of floor. So a frozen shoulder, meaning a beef cattle frozen shoulder sitting on the floor for housing. So here's a perfect example. Here's a patient, middle-aged woman, and you look and see, is it a frozen shoulder? She's coming to your office with pain. It can't be a frozen shoulder. She has great range of motion. Well, not if you compare to the other side. So you can see subtly that there's a difference. She gets this one up a little bit higher than this one. If you look from the side, this one doesn't go quite as far as this one. Out to the side, a little bit restricted. Up the back, very restricted. So huge, this can be easily missed for something else. But it's easy. It's picked up, it's done. We talk about what the next step is. And here's just another video of that, what it is, what it looks like in that subtle form. You can see this is a woman, and I had to try to block out her face, but I think I blocked out all the parts of the video I wanted to show you. But you can see as she raises her arms up, there is a subtle difference on that one side, on her left side. And you can see, again, it's hard, unfortunately, but when she turns around, I think you can see that shoulder, that arm doesn't go up the back. Yep. Now just reach all the way around. There's your face. Sorry. And you can see the difference. That one just doesn't quite want to get there, okay? This happens to the capsule layer. So again, this is deep to the rotator cuff. This nice big loose capsule that allows that shoulder to get around turns into an obliterated, tight, fibrotic capsule. This goes through 3 phases, and that recovery can really take a long time. It can take almost a year. The good news is most patients, like Danica is going to tell us about, get better with time, and that's gentle stretching exercises, possibly a cortisone injection. Only about 10% of these patients actually need a surgical release. When we do a surgical release, again, I get the benefit of showing the cool, fun stuff here. But this is the capsule. So here is the joint surface over here. This thick stuff is that capsule. It should be nice, thin, satiny fibers, and this one is thick. It's almost like leather. And you can see you have to cut through it. This is a tool that actually it burns as it cuts, so it stops bleeding. But again, here's the ball, here's the socket, and you just come up right through here and cut through this thick layer. And I'll just show you briefly. This is a biter type instrument. You come through and clip it away. And clip away, and behind that you'll see these are rotator cuff muscle fibers behind it. So you cut just enough, you cut the capsule, but leave the rotator cuff. Okay.
All right, so the rehab phase, we've nicknamed 3 different phases of rehab. The first is the freezing phase, which is when patients typically start to notice their symptoms. And this is very painful at all end ranges. So with flexion, external rotation, internal rotation, all directions it's limiting. And you can, as he showed in that video, it's just a thick capsule, thick synovitis, and it's very difficult to break through. In the frozen phase, that's when it's really stiff too. It's not quite as painful as the initial phases, but it's still very stiff, so they're still limited in flexion, external and internal rotation. And then the best phase is the thawing phase, and we get really excited when we start to see this because patients start to feel better, and all of a sudden their shoulder starts to loosen up a little bit. And going through all three of these phases can last anywhere from 3 months to up to 2 years, I've read in some articles. And they don't know exactly what causes it or exactly what makes it better, but our goal in rehab is just to reduce the pain, and that's the most important part. And that's, again, why people come to us. So typically, as the pain lessens, the patients move better. So that's the most important thing, is we have to control the pain. So we use modalities, again, to decrease the pain. We use some joint mobilizations to again, using our hands to stretch out that thick joint that you could see in the last video. And it's difficult to do. We have to put a little elbow grease into that and get things moving a little bit. And then we teach patients stretches so that they can stretch their shoulder on their own at home, so that they aren't coming every day for 2 years or however long it is to get over this, because insurance companies don't always pay for that. But it's a painful recovery, and then we also include the strengthening too, like I talked about in some of the rotator cuff rehab, and that'll help to increase function, and it increases blood flow to the area too, which can promote more healing through the shoulder. Let's see. Yeah, and then as pain lessens, we increase the intensity of joint mobilizations and stretches until normal movement is established.
We're going to talk about shoulder instability or dislocation. It doesn't always have to be a full-blown dislocation. You can have a partial, what's called a subluxation. So typically a younger person's type disease and injury, I guess you could say. This is a case of one that was actually dislocated and then neglected. This is a case down at the county hospital, and you can see broke off a piece of the bone and has been sitting there dislocated for a couple of months. This is the most common joint to be dislocated. It happens in about 2% of the population. Again, like I said, it's a younger person's injury, so half of these occur in almost teenagers. It's also more common in males, typically more involved in contact sports and competitive type things like that. It's generally a traumatic event. Half the time it's a sports injury. Usually we just start with putting it back in place. You hear about guys getting their shoulder wrenched back in on the field and that sort of thing, and we actually do that because it goes right back in on the field. You can oftentimes just get it to go right back in without too much trouble. All the muscles are in shock and paralyzed, and you can just put it right back in. But typically we get them by the time when they get to the emergency department. The problem is you can put it back in, but it might come back out again. And so in young male athletes, about at least half of them will dislocate again and then again. And it becomes very painful, inconvenient, and there are studies to suggest that that repeated in and out dislocation wears off that cartilage and causes problems when they get to be adults. The reason it's so common in the shoulder is that the shoulder doesn't have good bony stability to it. So if you picture what a hip looks like, it's a ball in a socket. It's very constrained. It's very difficult to dislocate a hip. Shoulder's a different story. You can see the socket on the shoulder is very thin bone. It's almost like a golf ball sitting on a golf tee. And the ligaments around there and the capsule are really what are primarily holding it in. It's not the bone itself. So it relies on this is called the labrum, and I'll show you a better picture of that in a second. But it relies on the labrum and the soft tissues. Again, you can see that's a thin piece of bone. Here's a little piece that broke off, and now you feel like you could almost just push that shoulder out of the socket. This is what it looks like when the humerus is taken away. So this is staring right at the socket. This is the labrum, and you've probably heard of the labrum before, and I think of it like a suction cup. It deepens and widens that socket, and it sort of holds on to the ball. And when the shoulder dislocates, it typically tears the labrum. And when we think of a tear, we think of like the rotator cuff tear where it's ripped off of something. But this tears a little bit differently. It tears along the edge. It doesn't tear in this direction like ripped tissues, but it tears like this. And so it tears off the bone. And this is called a Bankart lesion, named after a famous surgeon back in the 40s. But it rips that off. And now once that suction cup edge is ripped off, it's much easier for that ball to fall back in and out. Again, history and physical exam, this is not typically something I'm going to see in a 60-year-old sedentary person. It's going to be something I see in a 22-year-old football player. So the history and physical exam is still very crucial. But the image that we typically get for this is an MRI scan with dye injected. And the reason we do a dye injection is this is all dye inside of there. There's this white area. And what it does is it leaks into all the tissues. And you can see this is dye leaking into this area and demonstrating that that is the labrum that's ripped off, similar to that picture that I just showed you. Initially, we still try rehabilitation and non-operative measures, and it's often successful, which Danika's going to talk about. But we tend to lean towards operative treatment, or I should say that non-operative measures fail to fix the problem in certain patients, particularly younger patients, patients that continue to play at contact sports, and patients who have bone loss. You can see this picture here. This is the humeral head, but as that thing dislocated, it actually got punched in by the socket. So when it comes out and it pulls back against the socket, it's almost like a ping pong ball, and it indents on one side. And now, once it's back in place, it's in place, but if you move it in the right position, that dent can fall right back out again. So another reason why patients will sometimes need a surgery. This too can be done arthroscopic, or it can be done open. This is one where I really do favor arthroscopic if possible, because unlike the rotator cuff repair, this really does take a bigger approach to have to get in there and do this open. And here's just a picture, here's going to be a video of fixing that labrum arthroscopically. So you can see this is the socket, and that's that labral tissue pulled off, just like that picture I showed you. So it's okay up here, but down here it's ripped right off the bone. And so this is the ball on this side, you can see here. So with that loss of socket, the ball can fall right off. This is a freeing device. It's a medical grade spatula, and it lifts this tissue off. So when that tissue tears off, it can scar inward a little bit, so we have to get in there and dig it out, and that frees it up so that we can bring it back around. But we treat this very similar to what we do with the rotator cuffs, and you'll see we come down along the edge and take a passer. This is a sharp metal passer that brings a stitch around the tissue itself. And again, I've got now different portals with plastic cannulas where I'm working to pull these stitches, and here comes this stitch now coming through and around. So that's going to come up through that tissue and go down through an anchor. And here comes the anchor. And you can see again, there's the stitch back there, and it's going to lift and bring all that tissue back onto the socket face and hopefully prevent that ball from being able to fall back out again. These ones here you're talking about as one? The question was, it looks like it's two needles. This is the ends of the stitch, and that's the anchor itself. So the stitches actually run into the bottom of the anchor, and I pull up on the stitch as I'm putting the anchor in, and then I'll come down and cut those stitches. See, so this guy comes down and cuts the end of the stitch. And what it leaves is that tissue sewn back up to the face. Okay. I think that's the end of that video. Yeah, okay. Now we're going to talk about rehab for instability.
Okay. So first I'll talk a little bit about the non-surgical treatment, which is very similar to rotator cuff rotator cuff rehab as well. So as Dr. Magovern said, the shoulder joint allows for a great range of motion, which leads for a lot of instability too. So most people see their doctor first after a dislocation, who then decides if the patient is a surgical candidate or not. Even if they are a surgical candidate, sometimes they come to rehab before surgery to start to strengthen the muscles, and that leads to an easier recovery after surgery. But if they aren't going to have surgery, some of the things that we do are restore range of motion, like I've said in some of the previous slides, strengthen, and those alone can help lead to improved outcomes. And then again, posture and patient education. And it's important, again, this is important with the communication between the PT and surgeon, knowing where the tear and the labrum may be, and knowing how the dislocation occurred. And that can lead us to assume, certain positions to avoid. Typically, this is a common position where a shoulder is dislocated. So we teach the patient, avoid that position so that the tissues can heal. And then strengthening is important. Strengthening is important for the scapular muscles and the rotator cuff muscles. So strengthen initially, again, down at neutral, and then progress to these unstable phases as tissues have healed. And then the rotator cuff tendons, as you strengthen them, it can actually tighten the capsule because some of the rotator cuff fibers kind of blend into the glenohumeral ligaments and capsule. And so that can help to increase some stability inside the joint too. If the patient still has symptoms after this, then that's after PT, we send them back to the doctor, and that's where they can decide if surgery is then indicated. So once the patient has had surgery, again, we communicate as to what type of surgery, where the labrum was repaired, how big was the repair, and then some surgeons have certain protocols in the rehab process that they want us to follow. So most importantly, we have to protect the repair site. So we're protecting that suture that he just put in there. Make sure that that doesn't come loose, because then it defeats the whole purpose of having the surgery. But we also have to prevent hypomobility, which is the stiffening of the joint. So that's where we get in there and do some stretching. But obviously this happens after several weeks have gone by and the tissue's healed nicely. So. And it also depends on the physician's protocols.
Shoulder arthritis, it's a lot less common than hip and knee arthritis, and people assume that if they're older, they're going to have arthritis, but that's not true. Arthritis, we don't really know why it happens, but I see a lot of patients that are in their 80s and 90s and come in with shoulder pain, and they don't have arthritis. Arthritis is a very specific disease, and what it is the loss of that joint surface, that shiny joint surface on the end that helps it to move friction-free. This is a normal shoulder. This is an arthritic shoulder. You can see that this is the socket, this is the ball. There's no space between them anymore. If there were cartilage still there, cartilage you cannot see on an x-ray, there would be a space between those bones. So this is when you hear people say bone on bone, that's what they mean, bone on bone. There are also big bone spurs. Here's a big bone spur, here's a big bone spur. This is a very bad case of shoulder arthritis. There are lots of different causes. The major cause is osteoarthritis, and again, we're not sure what the cause is, but it's wear and tear, and it's probably genetic, and it's probably related to use in your life and diet and a lot of things, but we don't really know the answer. This is osteoarthritis, and I can tell just based on some of the characteristics of it. Big bone spurs, sclerotic-looking bone. This, on the other hand, is rheumatoid arthritis. Rheumatoid arthritis is when you have a specific condition where your body attacks your own cartilage, and it looks different than osteoarthritis. It doesn't have the bone spurs. It has thinner bones. The quality doesn't look the same. It looks like it looks more fragile almost. There are more cysts formed here, so that's a clear rheumatoid arthritis. Avascular necrosis is a strange one. This is from heavy steroid use, or if you had a bad autoimmune condition you needed to take steroids, or bad asthma or something. You can see this causes a real destruction of the joint. You lose the architecture. It's a strange one. And then there's post-traumatic. So when you have a bad injury, you can lose the blood flow to the ball and develop something like this where you can see that's just lost its cartilage. I will get MRI scans on these to look at rotator cuffs, but this is where actually a CAT scan is very helpful. So this, again, another study that we get. Sometimes people say, well, why not an MRI scan? Well, because a CAT scan is going to show me what the bone looks like. So here's, this is an easy one to do. This is concentric, the socket looks good, the ball is rubbing it nice and normally. Yes, there's no cartilage, but that's easy enough to deal with. This is a bad one. You can see this is where the old socket used to be, and it should come all the way across here, but this ball, because it's so arthritic, has worn its own new socket all the way across the back. So that's something that I have to try to correct at surgery. It makes my job much more difficult and makes surgery a lot, it makes recovery a lot harder. like these others, we almost always start with non-operative treatment. We're not really that eager to go in and do surgery because we'd like to get patients better without it. So physical therapy, I think, helps a lot in shoulders. I've found it more helpful in shoulders than I have in other areas of the body for arthritis, and I think it's because there's so much soft tissue to work on. Anti-inflammatories, so Aleve, Advil, if you're able to take those, they're very helpful. I do like injections. We can talk about the different types. Supplements I actually think are very helpful for this. So fish oil, omega-3s, they do tend to bring down symptoms of arthritis. When the pain gets to be too much, you've tried everything, replacement is a great option. It really is beneficial. This is the first joint replacement, first shoulder replacement that was done back in the 1800s. You can see it was made out of rubber and platinum. It's kind of a crazy configuration, but nowadays it's a little bit more advanced. This is, again, that shoulder arthritis, and now you can see after replacement, a new metal ball with a spike that's just sort of wedged into the humerus bone, and then you can't see it, but there's a plastic socket on here. This line is a marker that's embedded in that plastic, and that's so we can actually follow this on x-ray and make sure it stays where it needs to be. A conventional replacement, like I just showed you, requires a normal rotator cuff. There is something called a reverse replacement that's out now that you may have heard of, and this is if you don't have a good rotator cuff. This ball you can see is sitting very high up in the socket. This is similar to that video I showed you where the humerus was coming up out of the socket. A newer device is called a reverse replacement that has been out just for about 10 years, I think, in this country. And what it does is it puts the ball on the socket side, and then there's a plastic socket on the ball side. And what that allows the shoulder to do is now, instead of the rotator cuff being your rotator and your lifter, you don't have that anymore. So now the big deltoid muscle off to the side takes care of the problem and is able to move it for you. I'm using this for fractures now too, so elderly patients who are trying to put this fracture back together just is not going to work. You can see lots of broken little pieces. These are really beneficial cases to use this reverse replacement on, and you can actually regain very good function in these patients. The problem with a replacement is there's kind of no going back. So once you have a replacement in, you have to have some degree of restriction and restraint. You can't just go back to everything and anything you want to do. If it's in long enough, it's like any durable good. It's like a car, it's like an oven. It's going to break down at some point and loosen if you live long enough. So you try to wait until you really need it. It should be a last resort. They can get loose, they can dislocate, and any type of revision surgery is much more difficult. It's not just going to the shop and getting new tires. It's a much bigger deal than that. So as we know, I don't know if you all know the story of Bo Jackson. He went back and had to get his hip done about 3 more times. Here's a case of a shoulder replacement that was done. You can see this is actually that socket piece. Remember I showed you that marker. Now, instead of being up here at the socket, it's sitting down in the soft tissues, and it should be over here, but this is the whole socket piece that spit right out. It got loose and came out. So you do have to have some restriction and restraint with them. This is one reverse that is dislocated. This is a guy that was overly aggressive a couple weeks after surgery and dislocated his shoulder replacement. But the good news is if you really do it and get it done right, you can get a really cool tattoo of your replacement here.
So arthritis rehab can be difficult again, but so lots of pain, and then there's usually not a lot of movement in the arm. So we do what we can to decrease the pain and inflammation, and teach patients about posture and again avoiding those painful movements. For example, if it hurts to reach, pretend like you have a magazine under your arm and don't move your arm all day, and just keep all the movements in this pain-free range. We can do a little bit of stretching and a little bit of joint mobilizations, and just a little bit of soft tissue work too, and that does help a lot. There's a lot of times, like Dr. Magovern said, to reduce pain and get people back to in a normal everyday activity. It may not get you back to playing tennis or golf, but gets you back to just using your arm for dressing and bathing and eating and things like that. And then we do PT after shoulder replacements, or reverse total shoulders as well. Do a lot of strengthening and stretching for that. So many of you came here today because you want to learn how to avoid some of these injuries, or you may have some of these injuries. And I was hesitant to show some of these exercises because it's very patient specific. It's not for, these exercises are not for everybody, but I did show some of just the low level exercises that we do like to use sometimes. And if you do try these exercises, make sure they're pain-free. If you do have pain, it's a good idea to go check with your physician or PT about it and ask questions to make sure you're doing it properly. So the first one, this one right here, all it is squeezing your shoulder blades together. And the purpose of that is not only to, increase the upright posture, but it helps to kind of open up some of the subacromial space, which can decrease the impingement on some of those rotator cuff tendons too. And that's a very simple one that we'll teach patients right after surgery. This next one adds a little bit of resistance, so it's using what we call a TheraBand. It has a little elastic pull to it, and all it is bringing both arms out into external rotation, and then you give a little squeeze at your shoulder blades too. So it starts to strengthen not only the scapular muscles that I talked about earlier, but the rotator cuff muscles as well. This right here, again, most of these are using TheraBands, but at the gym they usually have cables with weights on it. So these are good ones to do on the cables too. Start with very low weight. I'm talking like the lowest weight possible. And then this one gives a little resistance. When you're squeezing those shoulder blades together, you pull that weight or elastic band backwards. And this is similar to a lat pull down, and you're getting some of those lower fibers of the lower trapezius, which can help to stabilize the scapula a little bit better. These are rotator cuff muscle exercises. So again, he's using an elastic band, and the pull is coming from this direction, and he's pulling inward. And then the picture on the right, he's pulling outward. So he's getting both internal rotation and external rotation. And I showed the picture in a neutral position because that's the lowest load, yet it can help to increase scapular stability and rotator cuff strength. So those are some good ones to try to start out. But again, I warn you, if you have any pain, go see your physician or physical therapist to make sure it's done properly. And this is a nice little sketch that we often use for people who sit at a desk all day. Most important thing, make sure your back is straight. You want to pretend like the spine is building blocks and that they're all stacked up nicely on top of each other. If you're slouched backwards, then there's more load through the lower spine and the upper spine as well. Shoulder is at neutral, elbows bent at 90 degrees, hip is bent at 90 degrees, knees at 90 degrees as well. For some people who may have shorter legs, sometimes they need a little footrest so that they're in this position. Otherwise, they have to kind of reach for the floor. So these are some key things to look at. And I look at this when anybody comes into the door to see me, especially if they're sitting at a desk for 8 hours a day. You can work out every day for an hour, but it's more important what you're doing 8 hours a day. So if you're sitting 8 hours a day, slouched, with bad posture, that's going to be more detrimental to your health than not working out. So posture is the most important thing. And this is a very, very common one these days. There's been some good studies that show the amount of force through the cervical spine when texting with your head forward it's astronomical, and it puts a lot of pressure on all those discs in the neck. And then it pulls on all those muscles that control the scapula too. And then she also has, you may not be able to see it, some forward rounded shoulders too, which will cause increased load on the rotator cuff tendons and some more impingement. So this is a more ideal posture. You rarely see it, but I applaud those that do.
I would say typically, yeah, if it's a new problem and it's nothing you've experienced before, I think it's always best to get the images and get the examination and all those sorts of things. If it's a recurrent problem that you've had before, or it's now on your other side and it feels the same, I think certainly going straight to the therapist is no problem. Long-term use of NSAIDs can have an effect on your kidneys long-term use of Tylenol can have an effect on your liver. So that's where those two kind of get separated. And so I leave that up to, I don't like patients to be on anti-inflammatories for more than, without an examination. If you're going to just pick up a bottle and take it from the store, a week or two is about the most I would recommend. If I'm prescribing them, about 30 days is the max that I like to do before saying that you need to be under the care of your primary doctor, who's going to be checking labs and making sure that kidney function is remaining normal. But I have patients who are successfully on anti-inflammatories for years as they're trying to stave off getting that shoulder replacement surgery done. And as long as it's done properly, usually not in my hands, I just don't have the resources to be checking labs and doing those things. So through the primary care doctor, it's a safe thing to do. But there are people that swear by a gluten-free diet when they do have pain from arthritis. I will never give up wheat and any of those things, but it is something to consider. You could certainly try it for a week or two. Short of that, I don't really have any dietary recommendations, just eating healthy and eating right and exercise. Supplements, the supplements that I typically talk to people about trying are omega-3 and what was the other one I said? Omega-3 fish oil, and then glucosamine and chondroitin sulfate. And that's what this says here, is this glucosamine chondroitin sulfate is good as a lubricant for joint pains. Glucosamine and chondroitin sulfate, which you can get at the drugstore, they are not, you don't need a prescription for them. They are components of that joint fluid that we talked about that sits in that bag. And the idea is you're going to take this pill and that joint molecule is somehow going to make its way to your joint. It probably doesn't really work that way. It probably doesn't make it there, but there are plenty of patients who really feel better on these. So it's probably worth trying. I don't think there's much harm to trying glucosamine and chondroitin sulfate. I just don't think, I think they probably are another form of an anti-inflammatory. Vitamin B complex, I don't have any specific recommendations, but certainly seems to be helpful. There are no absolute precautions after having shoulder replacement. I just reviewed a paper that looked, it was a questionnaire to 100 shoulder and elbow surgeons, and it was, what do you let your patients do after shoulder replacement? And it was, some doctors didn't let their patients play golf, and other doctors let their patients rock climb and do martial arts. And so it's all over the map, and there was nothing to suggest that one leads to deterioration of the implant faster. So the answer is, who knows? And great question, and ask this to all your doctors, because we don't know. So when we track a big group of patients with shoulder replacement, some of them are playing golf and some of them are rock climbing and doing martial arts. So on average, about 90% of shoulder replacements are still going strong 15 years after implantation. So for activities of daily living, which we consider bathing, brushing teeth, grooming, shopping, driving, likely it's going to last 15 plus years for you. The funny thing about calcific tendonitis, and it's not that common, and that's that first video I showed with that piece of calcium, is that the body will eventually get rid of that calcium on its own. So there's a resorptive phase months and months down the line. It's just that a lot of people can't make it that far because it is very painful. It's one of those things that people go to the emergency department for because it hurts so bad. So time does it. You just have to wait it out. And a cortisone shot can help bring down all that inflammation. Would stretching, therapy, massage help it? Absolutely, because it's going to help the shoulder move in better range of motion. But getting in there and, for example, using your thumbs to try to squeeze that out, I think it's probably too deep. It's not likely to do that. So when I give a cortisone shot, I actually try to poke holes in it while I'm doing it, and then I think that that helps bring it to the surface and let the body get in and get rid of it on its own. Synvisc is the trade name for hyaluronic acid. So similar to the glucosamine and what I was talking about, hyaluronic acid is the liquid form that is in these joints. and there is an injectable form of that known as Synvisc or Hyalgan or Orthovisc or Suparts. There are multiple trade names for the same thing, which is this injectable medicine. It is not FDA approved for use in the shoulder. It is FDA approved for use in the knee and the big toe and maybe the ankle and some other places. It doesn't mean I can't use it, and I do use it. I just have to warn you that it's using it off-label, which means it's safe but not proven effective. It is helpful, and it's a series of 3 shots. I'd use it in an ultrasound to put them in because you have to really see where you're going. And it's another one of the treatment modalities. So there's not one thing that will work every time. So if we've tried a cortisone shot, it hasn't worked, the next step might be to try Synvisc injections. So there are other, and my slide, I flew by it because we were running out of time, but injections, there are 3 or 4 different types of injections that are out there, and I just want to briefly talk about cortisone. I spend a big part of my day defending cortisone because cortisone is like, it's considered evil out there, I think. And Dr. Clapper, if you guys know Clapper, is on the radio talking about cortisone and never get a cortisone shot. And I would disagree. I think that a well-placed cortisone shot can not bandage things up, but can permanently cure certain conditions. So bursitis and some of the things that I talked about, frozen shoulder and calcific tendonitis, can fix the problem and get you to the point where you never have to look back on it. Yes, repeated cortisone shots over time are bad. They can degrade the tendons, they can wear down tissues, they can cause problems, but a one shot here and another shot in 6 months or a year from now, and then that's the end of it, can be very, very effective. So don't be as afraid of cortisone as is out there. That rotator cuff and those that I showed, the sutures exposed, and you can see that stitch out there. That's a permanent stitch. I don't go back and ever take those out. What happens typically is a layer develops over those sutures. So the body puts down its own, I don't know, protective film, if you will, that covers that area. So it kind of incorporates it. It doesn't reject it. It just stays there, and you want something permanent because you want that pushing down on that tendon for as long as it possibly can for healing. The next one, insertion. Infection is always a risk of surgery, so there's no way around it. We give antibiotics ahead of time. We use sterile instruments. We try to work quickly. The longer you're in there messing around, the more there's a possibility of getting an infection. But typically, infection is very low in an arthroscopic rotator cuff repair. You have water flowing in and out. It's cleaning out any bacteria that might get introduced. There's very little risk of that. It's uncommon. I have kind of in my own head, I have about a 2-week rule. I think if you have pain for more than about 2 weeks, it's something worth getting looked at. Particularly if it's an injury, if you have an insidious pain that just kind of came on and it's a nuisance and you can tolerate it, I might give that 6 weeks. The only do's and don'ts I have is that I typically tell patients, and I don't know that this is based on any science, but sharp stabbing pain during the activity is probably something that you should be worried about. If it's dull ache after the activity, maybe that's something to be a little bit less concerned about. But anytime you have any concern, you should just be safe and get it checked out.
Thank you.
More than that, it depends on what you did. So me as a surgeon, some patients, if it's a small tear, great repair, good quality tissue, I move them right away, sling off quickly. If it's huge tear, really rough tissue that I just barely get over to the bone and it's tenuous and I'm worried it's going to pull right off again, my joke is that I say no pepper for the next 4 weeks, because if you sneeze, your tendon's going to tear right back off the bone again. So see, and this is a great question because this covers a lot of areas. It's neck, it's nerve, it's shoulder, it's trapezius. This is something that we see a lot of. So, and this is an example of something that I would say to get checked out. So when you have numbness and you have weakness and those sorts of things, that would imply that there is something going on that could be damaging. So going to see an orthopedic surgeon, maybe going to see a neck specialist. We have 2 in our group. Neurosurgeons also are great. But this is probably something that once we get some imaging and we say, well, the x-rays look okay, maybe an MRI, that looks reasonable, we're going to send you to the therapist and have them start working on posture and stretching and strengthening and all the things that are going to help make it feel better. Again, surgery being that last resort, but this is something that can be treated by most orthopedic surgeons. So this sounds a little less concerning to me. This sounds like this is something that could very easily be treated with rehab, maybe some anti-inflammatories, postural techniques, but again, something that could be worked out and evaluated by orthopedic.
Thank you.
Yeah, shoulder clicking, grinding, noises, that sort of thing is always a difficult one because I'm never going to know what exactly it is unless we have a clear anatomic disruption. If it's non-painful, there's nothing to do about it, nothing to get concerned about. But again, it's in that category of you should probably just clear it and get it checked out.
Thank you. Oh, yes. So after they've completed therapy and they're feeling great, before discharge, I typically give people a good home exercise program to continue with so that their pain doesn't return. And we try to get them going on a good maintenance program. So whether that's going to the gym regularly or just doing their stretches at home regularly, we try to keep them from coming back again.
I didn't say this in my presentation, but almost everybody who has a frozen shoulder has minor measurable restrictions in that range of motion permanently. So they will have some loss of motion, but you wouldn't know it unless somebody got there and actually measured you. So it won't be a functional loss of motion. So you would expect that, the question says once it's thawed, how long would it take? Well, once it's thawed, it is thawed. And so that way might be 1 to 2 years of having this condition where you would regain that full functional range of motion. So labral tears basically cause instability in younger patients. They can cause pain in patients that are older. It absolutely does not, you can absolutely get by it. It's not bad to leave it unrepaired. The question is whether you even have a labral tear or not. So when we know that 6% of people have a labral tear, something like that. Yet when we get an MRI scan, almost every single MRI report comes back and says that there's a labral tear. Why is that? And I'm not quite sure. I think it's very difficult. It's easy to see the rotator cuff on an MRI scan, but to see labral tears is very, very difficult. So I think there are a lot of people being diagnosed with labral tears that don't really have them. So you can absolutely have a normal functioning shoulder and get by. If you do have one, it does not need to be repaired. If you're having a dislocating shoulder, that's another story. If you have pain and you have confirmed this diagnosis with your doctor and an MRI, and you've tried therapy and you've tried everything, then a labral tear is a good way to get rid of your symptoms. But you can always use more time, activity modification, waiting it out, seeing if you can get by, and you do not have to jump to surgery for a labral tear.
I guess I would start off by further inquiring, what type of activities have they tried to reduce pain? Have they tried different types of medications, or have they tried physical therapy, or what further things have we tried? After an auto accident, it is difficult, but the most important thing is to try to restore normal movement patterns as quickly as possible, and that leads to a better outcome. It is more difficult when it becomes a chronic case, such as it's been there, the pain has been there for more than 6 months, but it's doable. I've had some patients who've had pains for years, and it takes time. It doesn't go away overnight. It does take time and patience, but it is doable.
I think that shoulder replacement surgery is easier to go through than rotator cuff repair. So you have an arthroscopic outpatient 45-minute procedure, and it's 6 to 18 months of really rough rehab. Shoulder replacements, whether it's a conventional or a reverse replacement, is a relatively fast recovery it's mainly just relying on healing of soft tissues, but pain gets better quicker, and you can imagine it makes sense. You don't have that awful surface rubbing against itself anymore, so you kind of trade one pain for another. It hurts to have surgery, but it also feels better quickly because you now have a normal joint surface. As far as the reverse goes, my reverse rehab is pretty simple. I put patients in a sling and I keep them in that sling for 4 weeks because there is a risk of dislocation and they don't do anything. And then after that 4 weeks, I tell them you start using it for the next 4 weeks in functional rehab and activities of daily living. And then at 8 weeks, if they still have some weakness, that's when I get therapy involved and start working on deltoid strength. So I don't think it takes a whole lot longer to recover from reverse than a conventional. So that's a good question. I didn't really get to it. So early rotator cuff disease we talked about is all those same things: impingement, partial thickness tear, bursitis, tendonitis, and bone spur. They're all the same thing. And if somebody fails to get better, they don't have a tear that needs to be fixed, but they have basically a pre-tear, if you will, and they've done the injections and therapy and they haven't gotten better, the surgery that we do is to go in and clean off the bone spur. Now, everybody has a bone spur because we're just cleaning off the end of the shoulder blade. At the same time, we're cleaning out bursa and we're debriding the rotator cuff where it has any partial thickness tearing. So we're kind of addressing all of the possibilities while we're there. And one of those is always to shave off the end of the shoulder blade just in case that's contributing. So we kind of do it all together. But it's only necessary if you still have pain after trying all the non-operative measures to get better. So epidural is the space where it goes, and cortisone is the medicine. So we think of an epidural during pregnancy, it's in the epidural space, which goes from your brain all the way down to your tailbone, and it wraps around your entire central nervous system. It's a space with fluid in it. And during pregnancy, you get an epidural anesthetic. So it's a local anesthetic that's put in that space, and it numbs you from the waist down. Cortisone epidural, it's the same thing, but it's cortisone being put into that epidural space, and it coats the nerves that are coming out. You can get an epidural injection in your back, you can get it in your upper spine, you can get one in your neck because you have an epidural space that goes all the way up and down your spine. The cortisone is the medicine that goes in. So it is the same. You go for an epidural cortisone injection. CAT scan doesn't really offer you any advantage at that point. An MRI scan is a little bit more sensitive for picking up arthritis. So if you have mild arthritis on an MRI, the CAT scan is really just going to show you the bony architecture. So a CAT scan won't help you. The MRI is all you need. So you now have that diagnosis of mild arthritis. The question is, what do you do about it? You don't need any more studies. You need anti-inflammatories, supplements, physical therapy, all those sorts of things, acupuncture, you name it. You can try everything and see if it helps you. In the meantime, waiting till it gets bad enough that you need something done surgically. Yes. I think so. No, I mean, the biggest allergy is nickel. So nickel is a metal allergy that a lot of people are sensitive to, so they're really trying to limit the nickel that goes into metal implants. Allergy to materials is something we know very little about, and we will probably find out a lot more about in the next couple of decades. But it may be one of those reasons why some patients still have pain after they've had surgery and had implants put in. So it's a great question. We really don't know, but we think we're doing the best we can.